You have any disturbance in the voice? Should I switch off AC?
All right, good evening, ladies and gentlemen, and to everyone who's watching us live from various parts of the world. My name is Ruben Lobo, and on behalf of Team Dentist Channel.online, I warmly invite you to a power pack session that is going to start soon from now. Ladies and gentlemen, we have with us a very special speaker, a person who definitely needs no introduction. He's called as the implantologist of both the worlds, and you would understand that in a short while from now. Ladies and gentlemen, Dr. Shoukath Ali is a person who's always said that yes, when it comes to presenting and when it comes to sharing his knowledge with everyone. He's a passionate implantologist, a passionate dentist, moreover, a person who's a mentor, guide, friend, and above all, a person who will always say yes. When the time came for us to ask and request Dr. Shoukath Ali to be a part of the world's first virtual implant expo, we were kind of worried. What if Dr. Shoukath Ali says no? Because we don't have a backup as good speaker as Dr. Shoukath Ali. But ladies and gentlemen, he blessed us, and it was a superb experience for us to hear a yes from Dr. Shoukath Ali, like always. Dr. Shoukath, we couldn't be more happy than having you for this biggest implantology event, because you're one of those speakers who we can never forget when it comes to implantology. It is not because of your cases, it is not because of your practice, but it is because of your passion, dedication, and for the skill that you have to deliver your knowledge. Thank you, Dr. Shoukath Ali. It's such an honor to have you for the expo. Ladies and gentlemen, we have with us Dr. Shoukath Ali. Dr. Shoukath is a specialist implantologist who has 20 plus years of experience in dentistry and 15 plus years of experience in implantology. He's done various advanced programs under the Temple University in the United States and the Toronto University in Canada. He also has a master's done from Austria. He is one of the few specialists who holds a dental implantologist privilege license in both Dubai Health Authority, the DHA, as well as the Ministry of Health, Sharjah, UAE. He's an international trainer and a mentor and has been invited in various national and international CME programs in Austria, Germany, UAE, and India. Ladies and gentlemen, there are two worlds with different thoughts, behavior and performance, while talking about implantology. One speaks different language that the other considers absolutely wrong. Both are speaking science, still in the opposite direction. Both are proven perfect and successful. That is the story of conventional regular implants versus the Bicon short implants. Usually, implantologists attending one school of thoughts cannot digest the other in terms of surgery till prosthesis. Here we are very lucky to have with us Dr. Shoukath Ali himself, a person who comes from both the worlds and a person who speaks the language of both the worlds. He is mentoring in both the methods. So the right person who we have amongst us who can explain the methods and the pros and cons of each systems, along with shedding light and the advantages and the disadvantages. Ladies and gentlemen, presenting to you Dr. Shoukath Ali live.
Ruben?
Yes, sir. Please
Yeah.
slide.
Okay.
Perfect.
Okay. Good evening, friends. Is it audible? Everything is clear? Ruben?
Yes, sir. The audio is very clear.
Okay. Thank you. Thank you for inviting me for this wonderful event. And this is remarkable in the history. of implantology. First virtual dental implant expo. When it is coming as first, we are blessed with 10 days of continuous programs, almost from different parts of the world. And it's because of its unique nature. I always tell Ruben and the Dentist Channel online team to go for a apply for Guinness World Record event. I hope you will do that. So we have attended so many academicians lecture, so many clinical lectures, and here today's program, it will be purely clinically based, and it's not comparing both systems. We had our program on May 4th in Dentist Channel online platform. There we were discussing 10 different implant systems which I have been using my 16 years. And we were finding out, we were creating a way how to choose the right implant system which is available in our locality based on this knowledge. So one of the implant I was mentioning there was Biocon. So after the program, I have got so many questions, so many inquiries regarding how I will be using Biocon when I am using the other systems, because this is totally different. One is going east, the other is going west. So how both these science will be practically possible in one practice. Usually those who are practicing Biocon, they will be continuously practicing Biocon. Those who are doing the all other systems, they will be following that method. Both are right, both are successful, both are scientific. But the problem is when we mix both science, it will not work properly. So here there is no comparison of orange to apple, but just an introduction. Here is a first case, a short tooth. So patient has come for extraction and implant placement. So I have a long bone, very good bone. I can utilize all this bone for my primary stability. So I can use a long implant. So tooth is extracted and implant Strawman rock solid is placed into the place. But patient didn't want to load same time because you'll be seeing the coming X-ray. He has already done 4 implants from different places, and none of them were loaded initially. So because it is not loaded, it was very difficult for me to convince him loading is not a problem. But I just respect his opinion, and we have gone that way. So even though it's not loaded, it's a single stage surgery. You can see some small white particles here. These are the bone graft material we use to fill the jumping gap. And the system, the beauty of the system is each and every component is perfect, and it will give perfect result. That's the reason if somebody is using these kind of brands like Strawman, they will not change from that brand to any other brand because of the convenience. And this implant was SLA active. You can see the implant placement, and the other area, 3 implants here and 1 implant here. This is not my case, that's why I have blurred. So all the cases I am sharing here is from my own practice. So all the other things will be out of focus or blurred. The beauty is, this is the patient situation when patient come, and this is the situation after placing the implant and restoration. So the gum level is maintained and pink aesthetic is maintained because we maintained the underlying bone in the right place in the right way. So that's all about conventional dental implants. You may have a doubt, should I use a 14 implant in one premolar site? Well, I don't have to use, but same time, if I need some extra stability when I'm going to do it immediate loading, and if I have plenty of bone around, no harming going with 14 in premolar site. But the width diameter should not give any issue to my soft tissue. That is not the everyday practice. So it's a dream. The patient is coming with pocket full of money and with an abundant bone, with completely health conditions, everything is satisfied. That we very rarely see in our day-to-day practice. So here, this patient has come. She is diabetic and she's having some autoimmune disease. And both area she came for the implant. Periodontally compromised. This area is periodontally compromised. This area I was planning to do my first implant because I was little worried about her health situations. So when as usual, there is no bone here, so we can add bone, we can build bone, but all those things will not be a good idea in a patient with all these medical problems. So what I can do is I can use this bone up to here. I can place my implant and I can make a beautiful crown, but it will be little longer, wider, and solve the issue. And she has come to solve the functional issue. But the problem there, the inferior alveolar nerve is not going the right way. It is showing some deviation in the path. We know there are 4 different deviations we'll be seeing from the literature. And this deviation is almost 6.4% in the study. One of the studies done from Thailand and Japan. So we can expect 6 patients when we treat 100 patients with inferior alveolar nerve deviation. So we may have to send the patient for further CBCT or maybe MRI. And here, what I have choose, because I have already short implants in my practice, so I don't have to worry about this. You can see the outline of the inferior alveolar nerve curve. It's almost going this way. And when we do this procedure, it should never be with the block, it should be with infiltration. That's how we can save the procedure when we are doing it very close to the anatomical structures. So here, the drill is placed, and looking at the patient's eye, we know we are going close to the nerve, and one short implant, Biocon implant, is placed subcrustally. This is a prosthetic face. You can see the implant in the place and the restoration and little longer crown. Is it a problem? This long crown is not a problem in this case because you can see the upper anterior. Even this one is little longer. She is not bothered about that. And this is not in a visible area, so it's not a problem. But it can be a disaster. It can be a big problem if the patient is not happy with this, if the patient's expectation is somewhere like a normal natural tooth. So sometimes even in the second molar, or maybe upper first molar, patient will be more aesthetically concerned. In that case, it's a problem. So here the patient is happy, everything is perfect, and the crown is in place and the implant is in place. There is no paresthesia, there is no other complications of inferior alveolar nerve variation. Now, this is one of the most beautiful slide. I can show you one more case, one more case, which is more better, but this is one of the most beautiful one because this is showing bone gain in one place and usual acceptable bone loss on the other side. What is the science behind this? You can see this part. This is titanium. Once the implant is inserted, the abutment is inserted into the implant well, there will be a cold welding mechanism and this will be acting like one single piece. So this area, the bone in contact, it will get stimulation and it will get proper orientations and it will be like bone stimulation, and that area bone will be maintaining and actually not maintaining at the place, it will be gaining the place. We will be getting some bone after some time. When we place the implant, we always talk about acceptable bone loss per annum, then continuously in every year. But here they are talking about bone gain over the implant. And it's not a new system, it's being there around 35 years. And this is the only system following one science when all other brands of the implant, whatever is there available in this world, is following the other side. So why still this one can survive is because when we apply this science that is associated, that is exactly the right way, when we are doing this implant, it is the best implant you can imagine. Here you can see one same clinical situation. First molar loss, almost same kind of bone loss, so same kind of crown, same height and width of crown will be there. Same time, two different systems I have used. Here, because of the anatomic limitation or because of the inferior alveolar nerve curve, I have used Bicon. Here I have little more long way to go, so I have used a normal implant. But same time, the width of the ridge is a problem. Because the width is not allowing me to use a wider implant, I have used 4.5, that's enough for molar, but still in such scenario, if I use Biocon, a shorter implant, that would have been performing better than this one. This case I'll be continuing. Patient has come. So this is a small surgical gate. I have included this in the presentation because if any newcomers are there, instead of trying blindly, I always advise them, when we train students, always we advise them to make a custom-made surgical trial. On the model, they can do a small drilling and with some flowable composite, with some temporary flowable composite, they can make this one a small gate so that the surgery will be accurately and predictably done without any issues. So this is the beautiful osteotomy, and later prosthetic face, and the crown is in place. So patient is happy, everything is restored properly and perfectly. But still, in such scenario, if I get another chance, I would have preferred Biocon because of the performance, because the remaining bone, I'll be getting some bone gain over a period of time rather than bone loss after some time. So why Biocon is different? That was one of the most uh, one of the question asked most of the participants from our last lecture. That's the reason they wanted to include this topic in any of our coming presentation. That's why I selected the same topic in today's presentation. Bacon is not believing in saline irrigation because they think a rainy day will not give a good visibility. So when the rainy drops are there, we cannot see. So switch off the saline. When you drill the surgical phase, that's one of the biggest difference between the other system and Biocon. All other systems, when we are drilling, we need plenty of saline irrigation. But when we are doing it in Biocon, we should not use saline irrigation except the first drill. Once the first drill is done, then we switch off the saline, then everything will be doing with a very small, very low speed. Because it is low speed, we are actually collecting the bone in a very clean field. So if you ask your assistant, if you have both systems, if you ask your assistant, which one should I use in this patient? They will give you the Biocon. The reason is they don't have to struggle to do this suction with both hands. They can relax when the doctor is drilling. There is no suction, nothing. And in fact, we discourage to do the suction. We do suction and clean the site because we are collecting the bone from the site. So we don't want to wash away that bone. And they don't believe in primary stability. One of my friends is there. He has written a book on primary stability. He's a prosthodontist, Dr. Sajid from Saudi. See, there are any implant systems. When we talk about any implant system, primary stability is a factor which helpful in success, predictable success. But when we talk about the Biocon, they don't believe in primary stability. What they believe is if the round hole, put the round piece. So if you are trying to put this triangular one to the round hole, you will have to use force and you will have to break everything. So primary stability is not the one which Biocon believe. Instead, they believe in secondary stability. That is the biological stability, the stability coming after the bone maturing around the implant. So this is little difficult. These both are two different science. So always Dr. Suhail, one of my mentor, he used to tell, don't talk Biocon in front of students when you are explaining the other one, because they had the issue. It's an organization doing implantology course in Middle East. So in the beginning time, 12, 13 years ago, when they start, they used to train in Biocon as well as the other one. Then they eventually stopped the Biocon because when they train Biocon and when they train the other one day they will have to tell you have to use saline. The next day they have to tell you should not use saline. One day they will be believing in primary stability, the next day no primary stability. Zero primary stability is enough. So one day they will be talking about crown to implant ratio. The other day they don't believe in it. They don't have to talk about it. So here, one of my practice in Dubai is in Business Bay. There, every day when I go to the clinic, I see this Burj Khalifa. The Burj Khalifa is 828-meter tall building, but the foundation is only 50-meter long. That too, this diameter foundation pillars, that is in 50-meter deep. It will be staying on rock beds with the spaces in between. After that 50-meter only, 20-meter concrete slab is coming. Altogether, if you calculate, this 828-meter tall building is laying on around 70-meter foundation. So what does that mean? Any buildings, any big buildings in all around the world is not having same length of foundation to deep into the earth. So that is the artificial way. When you are talking about the natural way, I am from India. You may be heard about Kerala. So in Kerala, the name Kerala itself is because of these coconut trees. Keram is Malayalam of coconut tree. So everywhere, wherever we turn our head, we see these coconut trees. Actually, this is a nostalgic feeling when you look at this from Dubai. So these coconut trees, it's having heavy coconut leaves and lot of coconuts in all around. But this is having a small, only this much implant. This is the implant to crown ratio when you look at the natural coconut trees. Same time, do I have to use, or is it wise to use every place these short implants? Definitely no, because this case, you can see a very thin ridge. And this patient has come only to restore the upper anterior teeth. You can see in the surgical phase, the dates are given here. It's in 2013. You can see 13 means 7-year follow-up is there, because I used to call my patients and regularly do this oral prophylaxis and this follow-up. That's very important. So this case, the width of the bone is very thin, but the length of the bone is enough to place the implant without vertical bone augmentation. You can see the implant I have used here is 16 mm. This from Implant Direct, one of the system from USA. You can see a lot of bone augmentation procedures. And finally, this is a 2-stage surgery. Finally, we have got enough soft tissue and enough bone. Later, everything is restored. And it's a restoration phase. Even though the bone augmentation is there, you can see the angulation, but it is managed with, even without angulated abutments, same abutment with some trimming, it's managed. So here you can see the healing abutment is placed and that is removed. So beautifully healed soft tissue all around the implant. And this is a prosthetic part. Once it is finished, it is perfectly done. Now, it's a bit confusing because some places we want to place the long implant. Some places we want to place the short implant. So our practice will not be complete if we don't have these both worlds, both type of implants. Because every time when the patient come, they are coming for the implant, and if there is no enough bone, we will have to build the bone then place the implant. But that may not be possible in every situations. Here you can see another patient. She is diabetic and 60 plus year old. She came to place 2 implants here. Actually, I have done some other implants on the other side also. The problem here is I don't have enough space between this area and the sinus floor. So we do a lot of sinus augmentation, sinus floor elevation. When we are doing it in Biocon implants, it's called sinus floor transportation. So it's a little different method, but doing the same thing. So here, I don't want to lift the sinus because her diabetic sugar level is always very high. So 2 implants are placed, 2 short implants are placed. When you look at how short it is, you may be not happy to see that. Every time when we do the drilling, we collect the autogenous bone and we place it in the same place when we are doing finishing this procedure. Above that, I have used some synthetic graft material also. You can see the size of the implant is 6 here. So not 6. 6 is the diameter actually. The size is 5. So 5 mm implant is the implant I have used in that molar area. Is it make any difference? Does it make any difference? Is it going to be a problem? Let us see. So all these round bowl shaped implants placed subcrustally, then this is the augmented bone and this is the matured time, and implants are in place and abutments are in place into the implant and restoration is done. After that, now you can see some area little bone condition is not as good as all around this, but later during the course of time, this area also will get new, very good quality bone. If you think that is too short for a molar, here is another case. This patient actually came to remove the 3rd molar. He is a little afraid of the procedures. So when I remove the 3rd molar, that's why you see a little more blood here. When I remove the 3rd molar, he was little confident. Okay, he said, if you are doing now, okay, you do same numbness is very good, you can do the implant also. But usually when I do molar implants, especially in this area, I never block the nerve. But here nerve was already blocked. So, and the nature of this tooth I have removed was completely abnormal. You will see in the coming X-ray. So I don't want to go very deep till giving a problem with the inferior alveolar nerve. Since nerve is already blocked, there is no signals patient can tell me till I hit. So here you can see this is an autogenous bone collected from the surgical site is placed again, and this is a prosthetic phase. The healing abutment is in place. This is a crown in place. Now, during this procedure, this is the area our healing abutment has gone. So this is semicircle, this much is punched out and this much is moved towards the buccal. This is how we try to save some soft tissue on the buccal aspect. You can see the procedure. The punch will be used only half. The remaining will be positioned towards the buckle, buckle side. So we will get a beautiful emergence profile and beautiful soft tissue all around. Here you can see this is the abutment. So this big part is completely going to be buried inside the gum. And you can see it's a 5 mm length. You can see the ball inside. This is what I said. The molar shape was this way, and inferior alveolar nerve was somewhere here. And a long time after the extraction, this area bone was giving some bone loss was there with from buccal to lingual as well as from top to the bottom. So I didn't want to go very deep, and same time I wanted to go as deep as possible to place my 5 mm implant. So this is a healing phase. Everything started healing. And this is the beauty. You can see the implant is in round, and this is the abutment, another round. The crown is above that. And you see the bone gain over a period of time. The entire thing is inside the bone. That means we don't have any space between this abutment and the implant for the bacterial influx. So this thing is acting like one single piece now. So even though you have placed 5 mm, you have to measure from here to here if you are measuring the length of the implant. So literally I have placed something like 10 mm. And the advantage of Biocon, these fins, this area, when we prepare the site, we are preparing exactly to the size of the implant. So the implant will be always kissing the blood, not the bone, like the other systems. All other systems, our implant to bone contact is the main issue. So we want to get maximum primary stability, and this primary stability is a factor when we are giving it above the bone level. All these Biocon implant which do not want primary stability will be submerged completely inside the bone. So there is no micro motion in that area. I have done immediate loading with Biocon, but that cases I was preparing little under prepared osteotomy, and I was tapping the implant deep into the osteotomy. But that time the science will be working not exactly like Biocon. It will be working like the other systems. Biocon will not change. It didn't change for past 35 years. And all other implant systems, like our cars, every day new models will be coming. Like every 2 to 3 years, there will be some changes in the implant system. So something is not changing, will not survive in the market. Why Biocon is surviving in the market? That's a big question, because they have done their changes 35 years ago. That's why they don't have to change every time. That is about this platform switching. Now all the implant systems started talking about platform switching. The first design of Biocon itself, you can see the platform is switched. They call it sloping shoulder. So in this area, the bone will start growing above the implant, and when the abutment is coming there, and when the stimulation is transferring to the bone, the quality of bone all around the implant will be improved. We know, we are familiar with the lamina dura around the tooth. The thickest part of the bone, when we remove, if you think the posterior maxilla is the weakest bone, why we are struggling to remove one first molar from posterior maxilla? Because even though the maxillary bone is very soft, the bone around the tooth, the holding part, is very strong. That is the same thing happening here. when the implant is inserted into a loose well with zero primary stability, that area, there will be blood flow into that area. That blood, which is immediately all around the implant, will be turning into good quality corticular trabecular bone, cortical bone. So same like lamina dura, this area, the good quality bone will be there, and that is the success behind this implant system. But when it is coming to immediate loading, when something is coming upwards, we have to use very short well, and means we have to use a under osteotomy, under prepared osteotomy, and the implant will be inserted with very heavy force, because we cannot turn it and insert. So how we will be doing that? Literally, we are having a mallet and we are holding it and tapping it. That tap is not a pleasant feeling for the patient. That's one of the reason people are going away from Bicon. So here you can see the follow-up X-ray. Again, the bone has improved all around the implant, all around the abutment. And that's what we want. Even though it's a very small thing, when you look deep and deep into the Biocon system, there are so many things, so many amazing things. So here I'm explaining how Biocon implant will be placing into one patient's mouth. Here from A to Z, all the surgical procedures are there. This patient is 6.2 height and with a very muscular body, and definitely with heavy occlusal forces. You can see the, after reflecting the flap, this is one of my method to get the perfect visibility to the site. Actually, these 2 or 3 sutures will be as good as one assistant, because it will be all the time reflecting the site for us to do the implant very easily. And this is a bone I was collecting from the osteotomy site. You have seen the site, how clean it is, because no too much saliva, saline irrigation, no too much saliva flux. So everything is in a clean site we are doing the surgery. You can see beautifully prepared osteotomies. And my first implant I am placing with my hand. There is nothing to turn, no torque wrench, nothing. Just placing with my hand into the well, and the next one into the next well, and next one into the next. So this is the carrier. And this rubber carrier, I don't have to take it out completely. I'll be cutting at this level. So the well of that implant will be sealed with this one. And in future, when we open the site to do the impression, these plugs will be there and it will be removed. And this is after healing. So here I have used 6 mm long implant, 5 mm wide, 6 mm long. Everything is same size. And this is a prosthetic face. I'm taking my impression now. So all these are impression post I have placed into the implant well. It is deep inside the bone. So I have one special instrument to trim the bone around the implant. Then these are the abutments seated into that implants, and the crown is in place. You can see the pre and the post. If you ask me why I did not use the other system, because the width of the bone was not that good. So if I use the other system, minimum I will have to use one more implant. I will have to use extra one more implant. Otherwise, the force factors will be a problem. When it is Biocon, the wherever I have used Biocon, it's actually inviting force. When we use the other systems, we are giving some a little bit clearance, but when we are putting the Biocon, they are asking to occlude into the opposing tooth, because that stimulation will be giving good quality bone gain all around the implant. So everything is different. So that difference will be there in prosthetic part. There is no screw. We don't have anything to test the ISQ values. We don't have such things in Biocon. All what we have to do is to know whether it is okay or not. Just take a radiograph, just insert your one small tool is there and just tap it and see. These all are very simple things, simple way we used to see whether it is ready to load or not. So now, after listening to all these different cases, actually, some of you may be thinking, in that case, one patient will be having different types of bone. So in that case, is it a good idea to use different implant systems? Usually when we talk about placing multiple implants, we stick on to one system, because if in future, if somebody else is going to do any other work on that implant, they should not have to struggle searching different screws and different abutments and all. So usually we follow one brand in one mouth. But here, this case is little different. This patient has come in 2000, I think 10 years ago. Here, she came with chronic pain in this area, upper maxillary area, and it was already a root canal treated and failure history, and finally removed the tooth and 2 implant placed. So when you say, when you hear remove it and place, why you didn't try a re-root canal? Actually, 3 different doctors have tried, including one of the experienced endodontist in neighborhood. And finally, they advised to remove it, because anything in this patient, any root canal is done, some way or other it failed. All these are not done by me or from our clinic. Actually, after this failure, she has reached into our clinic. Then we have done some other treatments also, as usual. But this case, 2 implants is removed and conventional implants, Marriott, is placed. You can see cement retained crown is given here. The story didn't stop there. Then this failed. You can see some zinc oxide eugenol here. This time we were trying to save this one, re-RCT. Again, that didn't work. So that also got removed after a few months. And here, after removing, I have done some bone augmentation, because she was not ready to place implant immediately. So I have used some synthetic bone graft material, and it was staying there till 1.5 years when she came for the implant placement. So the implant placed. Now you can see I have removed the previous crowns, because she don't want to have a connected crown here, because she find it very difficult to clean and she don't like it. She is maintaining oral hygiene properly, but this area is always a difficult issue for her. So she has, I have removed the crown. Then later it is also placed screw retained crown. Here you can see the site after healing just before the implant, and that 3 implants are placed. Then she started coming with the pain on the lower. There was a crown bridge, and that is removed, and the tooth is removed. Now you can see here bone quality is not quality is good, but the quantity is not much. So here now this time I was doing biocon. The reason is she don't want a splintered implant in her mouth. Whatever I do, no problem, but implant should not be splintered. Everything should stay like natural, normal, natural tooth. So I have done biocon, and this is after healing. This is the impression stage, and this is the healing abutment. This bulk healing abutment will give shape the soft tissue, as well as it will maintain the bone exactly the way we want to be when we are inserting the abutment. So that's after healing, and you can see the beautiful healing. And this red area is a good sign, because this is once a healing abutment is detaching, the hemidesmosomal attachments will be disturbed. So that's why we are getting some bleeding. So when we insert the next crown abutment area, that also we expect to be same way like this. So here is the implants inside. These two are biocon implants. In biocon implants, these are the small diameter. It's a prosthetic face, and crowns, everything is right place in the right way. And now you can see every implant is separate. Is it a good idea? I don't have a problem. I am not worrying about this lower, but this area is little concern. But patient is reporting regularly, and she like this. She don't want to connect it and splint it. So this is the, and that's it. So now these short implants, there are a lot of advantage, there are a lot of plus points, but some situations I preferably not use. This case, you can see a thin bone. So I have done osteodensification. So when I do osteodensification, some people, they asked me, this mandibular anterior area, how can you densify the bone? Here you can see the CBCT. This area, the cortical plate is here and here. I was splitting this center, and I was using this inside portion to densify and expand. So peacefully, I could place 2 Straumann implant, our regular conventional implant there. This is a sinus lift case. You can see lower everything is biocon, but upper sinus lift case, even though flow transportation is a good idea, but that tapping sometimes patients will not like. Not sometimes, most of the time. Because instead of all, when I use this osteodensification method now, the sinus lifting will be with my rotation of this burr. It is not giving any force. It is with a very slow incremental lift is happening there. But when I use it biocon, I have to tap it and break it and push it inside. So one is with lot of noise, one is peaceful. So I always go with that peaceful way, because patients are they appreciate that. And after that, once if I lift that way, then I can use our conventional implant, not Bicon implant. If I have to use Bicon implant in sinus lift cases, then I have to lift the sinus the same way as regular sinus lift, same floor transportation method. Otherwise, also I can do lateral sinus lift, I can do. But the point is, when I am lifting the sinus that way, why I have to go for a small implant? Because the surface area will be more, because the quality of bone inside the sinus, even after augmentation, lifting will not be as good as one in the mandible. So I have to use maximum surface area implant. So I use bigger, longer implant in such scenarios. Here another situation, this patient has come for extraction and immediate implant. And here you can see it's a single stage surgery. And this, after this all root stem extraction, this single stage surgery would not have been possible if it is Bicol. She don't want to cut the gum after some time. So it should be single stage. So this stage, if it is a single stage and such a scenario, then I should use our normal implant. Then I have to get primary stability. Then only I can give a healing abutment on that. And this is another situation. Here patient came with a broken vertical fracture, so tooth is removed. Here you can see the interradicular bone. I was expanding with the osteodensification method. Then implant is placed and some bone graft is placed, and everything is sutured. You might have seen the torque also. This is another scenario. Two different orthodontists. One is Dr. Shams Mopen, and one ortho, after ortho, canine was not there. So he created the space, then I have inserted the implant. And here, Dr. Shaji Wahabuddin, he, during the procedure, during the orthodontic treatment, two implants were placed. So this also, I was not using Biocon. And here, if by mistake, if anybody use, this is a disaster. The anterior area, this is Biocon, my own case. The problem is this deep bite. Any deep bite can give some disturbance to our implant. So here, this deep bite, the problem was Biocon implant abutment will be, or crown will be inserted to the implant with tapping or with vertical force. How we remove it? We hold it and twist it clockwise and anti-clockwise. It will be breaking the cold welding. So here the problem is that force will be continuously there every time when the patient bite, the clockwise and anti-clockwise. The rotational and derotational forces will be there. So eventually this will be loose and coming out. These all are in the long way when we start our journey. But now from our failures, we train our students not to make same mistake.
Doctor, please wind up your presentation. Thank you.
Yeah. So I'm finishing it here. This is the last one. Another sinus lift case. I will go quickly. You can see the sinus membrane and placement of the implant. This is about my institute, Do It Institute, Dentistry Online Implantology Training Institute. I'm one of the member in that. And all what we are doing is giving training. It's a non-profit organization, giving training and answering questions to those who are doing implant from different parts of the world without any financial interest. But definitely we are getting something more than that. That is a happiness from the feedback of our students. Thank you very much. Thank you, the Dentist Channel online team, for this wonderful event. And definitely this will be marked in the history of dental implantology.
Dear Dr. Shoukath Ali, thank you so much. It was a wonderful session. Friends, as Dr. Shoukath Ali has already mentioned, that the Do It Institute is doing a wonderful job. It's a non-profit organization. If you wish to be a part of the Do It Institute, if you have that zeal, passion, sure dedication, it's only for the serious people and it's not for everybody. You know, some things are never free in life. One of them is the Do It Institute, which is not charging you anything but will only request you to be a passionate implantologist. And if you wish to be a part of Do It Institute, please do get in touch with Dr. Shoukath Ali. I'm sure he will be more than happy to mentor you, to guide you, and to help you to give that right smile required for your patients. Friends, I'm sorry to tell you that we are running short of time and hence we won't be able to take the question and answer session. However, if you have any questions, please message us at info@dentistchannel.online. We will pass it to Dr. Shoukath Ali and we will request our speaker, Dr. Shoukath Ali, to answer them later. Thank you, ladies and gentlemen. I hope Dr. Shoukath Ali has given you a wonderful insight. Dr. Shoukath Ali is always that wonderful personality. Undoubtedly, we are always sure that Dr. Shoukath Ali's lectures are always, always, always and forever successful. And this was one of them.
Thank
Thank
you
you,
very
Dr.
much.
Shoukath Ali. It is people like you who have blessed us. And that is the reason why this expo is a grand success. We seek your blessings. We seek your wishes so that we can continue the good work we are doing, like you and your institution, the Do It Institution. Friends, before I wind up, I would like to invite you for the next session. Once again, it's going to be an amazing session. It would be on the topic implant occlusion, reality, objective, or a myth, subjective. Let's fine tune it with digitization occlusion using T-scan technology. We will be having with us Dr. Prafulla Tomati, the man for T-scan in India. Please do register for the session and we hope to see you all for the next session. Thank you, Dr. Shoukath Ali, and thank you
Thank you
so
very much.
much to everyone who attended this session. Goodbye and have a good evening ahead.
Bye. Goodbye.